I had my own title, and so they wanted to call it Mental Health Crisis Evaluation and Clearance from the Emergency Room or Office Setting. So let me give you just a little bit of an introduction. I did my Air Force training in San Antonio. I've been primarily at McKay Hospital, but I've also done a little bit of moonlighting at Lakeview Hospital. I've worked for LDS Family Services with their missionaries. I've worked with the jail at Weber County, and so I enjoy, one of the nice things about psychiatry is being able to rotate around and work in different settings. So I'm going to go ahead and jump into something that's very near to me, obviously, but I'm hoping that it can be useful to you. By way of disclosure, I do and have spoken for a drug company, but we're not going to be talking about any psychotropic drugs during this lecture. So here's our outline. The first point that I'm hopeful to get across is that suicide is really a public health problem. It's not just something for mental health professionals, and it's not just a problem for medical professionals. We're going to talk about this a little bit more, why that is, but what I'm hopeful will happen is that this information that you learned today, that you'll pass it on to your friends and family, and that it will spread so that it's just part of how our society operates. Suicide continues to be a greater and greater problem all the time, and unless everybody's on board, we're going to have a difficult time being able to turn that around. When I was in the Air Force, they taught us, you take care of your wingman, or in the Army, they call it your battle buddy. And they were doing a very good job when I left about making sure that people were educated. Everybody was educated about suicide prevention, and the things to look out for and how to help other people. We're going to talk just a little bit about risk assessment and then risk management as well. And although those areas are a little bit more geared towards people in the office setting, it's still applicable to everybody in one form or another. So here we go. So let's talk first about just suicide in general in the United States. Suicide rates have risen nearly 30% in the last 15 years. Every single state, the rate of suicide has increased except for Nevada. And that doesn't necessarily mean anything special for Nevada because they were already way up there to begin with. We're just all catching up with them now. So don't think that by moving to Nevada you escape the problem. It's the 10th leading cause of death overall, and it's the second leading cause of death for those that are ages 15 through 34. As I mentioned, the rates are up for everybody, but women, the rates for women are surpassing that. As far as the increase for men, they're catching up to men. Now let's talk specifically about Utah. Utah is a wonderful state, but we don't do so well in regards to suicide. We're the 5th overall in the nation, and we've been higher than the national rate for more than 10 years now. And for those aged 10 through 17, it's the leading cause of death, not the second, as it used to be, behind motor vehicle accidents. To give you an idea how prevalent suicide, just the risk of suicide is, they gave a questionnaire to students that were between the ages of 8 and 12, or grades, sorry, not ages, 8 and 12. And so I guess the class size at the time was 36, which to me seems a little bit big, but just try to imagine back when you were in high school and think about your class and just wonder how many people during that year would have had serious contemplation of suicidal thoughts. And the answer is 6. So 1 out of every 6. So when you're sitting in your desk and you have 1, 2, 3, 4, 5, 6, 7, one of those people right around you, if it wasn't you, is one of those ones that's having suicidal thoughts, serious suicidal thoughts that year. So we talked about this just a little bit. Why is it a public health problem? Why is it not just a mental health problem? Well, this is a little graphic that comes from the Deseret News, but what it shows is that the majority of folks who commit suicide did not even have a psychiatric diagnosis that had been made at the time of their suicide. So if we're going to wait until it's just people that are being taken care of by mental health or medical professionals even, you're still going to miss a lot of those people that are at risk. This is from Kimberly Myers. She's the Utah State Coordinator for Suicide Prevention and Crisis Services. It's part of the Department of Human Services. And she said it well, we're never going to have the opportunity to rely on just one strategy. There needs to be a comprehensive approach touching all systems, all community partners. So to me, what that means churches, athletic organizations, you name it, everybody needs to be involved in this. So a little bit about why Utah. There's some hypotheses as to why Utah might be high. Some people think it may have something to do with the prevailing religion. Other people have wondered if altitude makes a difference. But I've got what I believe, and I'm going to show you right now. So this graphic right here, some of this stuff is a little bit older information, but I still think it's pertinent. What this shows is the rate of increase. So you'll notice Nevada, like we mentioned before, they were already up and they've just kind of stayed that way. And then all these red states here, these are states where the increase is between 38 and 58%. The blue states, the dark blue states, the rate is up 31 to 37%. So that's over here in this area. Then you've got the light blue, and that's 19 to 30%, which is not low. I mean, that's a pretty high rate of increase, right? And then the light orange, where it's just a rate of 6 to 18%. So it means everybody is increasing, but there are certain states that are increasing particularly fast. And look at that geographic. They're kind of in the same area, a lot of them. And now here's another graphic I want you to look at. And this is measuring something quite different. This is just the suicide rate overall at just a one-time given point. And I can't remember. This was in 2014. But look here, you can see numbers 1 through 10. Number 1 is Alaska, by the way. Here's Utah, number 5. Wyoming is 2. Montana is 3. Look at this, a lot of same overlap as far as geographical area. So why would that be? Well, it happens to be that these are states where there's a high amount of gun ownership. And I'll jump forward and just share with you, I'm prior military, I'm okay with people having guns, but it's important that, and the bottom line that we're going to talk about is we need to make sure those guns are secure and that people are having proper responsibility in how they take care of them. So look at this. I think this is very compelling. They take high gun ownership states and low gun ownership states and they compare them. So we're going to jump right to here. This is back from 2004, but they're looking at population. The low gun ownership states and the high gun ownership states are about the same. So from groups that are about the same size. Then they look at how many had firearms in the home. The low gun ownership states had 15% as opposed to 50%. Now look up here, suicide attempts. This was in 2008 and 2009. The suicide attempts were actually higher somewhat in some of these low gun ownership states. 303,000 as opposed to 246,000. But how many were successful? Almost double in the high gun ownership states. And so here you go by firearm, they have it divided out. And then by other means. And by other means, they're exactly the same. So what this means is that in almost every state, you've got about the same number of people that are attempting suicide. But in some states, they're very successful. And the relationship here, and what the implication is that it's probably due to access to guns. So we're going to talk a little bit about why methods matter. So this is a story about Sri Lanka. And you're going to wonder, what does Sri Lanka have to do with Utah? Well, Sri Lanka used to have access to high toxin pesticides that anybody could have access to. In the mid-1990s, they had one of the highest suicide rates in the world. Some of the risk factors included that they had a high level of unemployment, there was a civil war, there was a lot of alcohol, but they also had access to this high toxicity pesticide. So they made it so that you could not have access to it. It was hard to get. You could still get a lower toxicity pesticide. After they made this change, suicides dropped by 50%. Those that were attempting suicide by pesticide, that was still the same. Those that committed suicide by other methods, that was still the same. So you can see what the implications would be for Utah if we were to be able to make it so that being able to access your guns was not as easy a thing. And I think this is a quote by somebody, and I should have put the name, but the notion that those highly determined to commit suicide will find another way is for the most part untrue. There are those, I've seen that happen, where there are some people that are very committed and it does happen, but that's not the majority. We don't usually like to publish this information because we don't like to get out there how people can be more successful in being able to commit suicide. It's amazing what people will tell you as far as the amount of effort they put into their research and how they committed suicide. But just comparing two methods alone, which is the highest fatality risk method and the lowest fatality risk method, firearms, this dark red here, that's your risk of completion when it's a firearm. And there are some studies where it's even as high as 95%. Versus overdose, which is probably our most common method that's attempted, it's only 1 or 2%. Rarely are they successful. Here's another study. They looked at survivors of suicide attempts, and they asked them, between the time that you thought about suicide, how much time was it between the thought and action that was taken? So the question is, how many answered less than 5 minutes and how many less than an hour? Both of which are relatively short time frames as compared to what you would think of, right? Whoops. Okay, there we go. So 24% answered less than 5 minutes, so a quarter. 75% said less than an hour. And a different study for time, I had to shrink this down to make it fit half an hour. There was another study that said 50%, 10 minutes and under. So what that means, or the take-home points, is that when a crisis takes place and somebody's suicidal, these episodes are usually relatively brief. They can escalate really rapidly during that time, and they're extremely difficult to predict. So trying to decide in advance who's at risk and then take action is probably not a good idea. As far as waiting till somebody's at very high risk before you implement steps. Some methods, especially gun, are more lethal than others, so you can't undo it. And the last point here, 90% of those who attempt and survive do not go on to die by suicide. So a lot of people that try suicide, that's their only time that they'll do it, and then they get over it. So if you can put time and distance between a suicidal person and a highly lethal method, especially a gun, you hopefully can save their life. All right, so we talked a little bit about why this is a public health issue. We touched a little bit in advance upon why methods matter, which is part of our risk assessment and our risk management. Psychiatrists don't like to call risk management, they don't like to call it suicide prevention, because that implies that each individual you can prevent. In population, I understand why we're saying that. We're trying to reduce our numbers. But we'll talk a little bit more about risk assessments in general. So the reason I'll leave that alone in the sake of time. So when we do assessing risk, we're really talking about the imminent future. The further out you go, the harder it is to really be able to determine the risk, because there are so many different factors that can change. But a risk assessment is reasoned and inductive as opposed to a prediction, which is kind of like a guess. And then it also allows you to identify the risk and the protective factors. And that's one of the reasons why I am in favor of a structured risk assessment interview. Risk assessments help us determine the level of risk. When talking about risk, there are two different types that we talk about. We talk about static risk factors, so things that can't be changed, and dynamic risk factors. Static risk factors are still important, even if there's nothing you can do about it, because if the risk is high enough due to even mostly static risk factors, that still may lead you to take a higher level of invasive or corrective steps. But The most important part of this is that there are certain risk factors that are modifiable, and what you want to do is try to pair up, and this is in our treatment plan, try to pair up the things that will help address those particular risk factors. A good assessment, not only is it a good assessment, but it can be therapeutic in the process of getting the patient involved, getting their family involved, getting them to think about things a little bit more, developing a therapeutic alliance. So here we are, just a little picture kind of showing that idea between risk and protective factors. There are some special considerations for youth. One are those that are bullied, how much screen time they spend, connectedness to their family, church organizations, friends, and community, and then the LGBTQ folks. So this comes from a questionnaire that they do every year, and then they put this information out, and it's always a few years behind when we finally get the final results, and they do this every few years. But look at this. If somebody's being bullied at school, the odds ratio for them goes up to about a little over 4 for a risk of suicide. Whether that's in person or electronically. And then if you combine both of them, the risk goes up to almost 6, which is really high. I think this one's fascinating. People ask me, well, why are the rates of depression and anxiety and suicide up? Well, there's probably a lot of reasons, but one of the reasons I truly believe is social media. And we just had something come out on that recently with Facebook. And so if you spend 3+ hours of daily screen time, your risk is double that of those that don't. Now, this is also interesting for those that are worried about how religion may actually be harmful. Those that are involved in weekly religious attendance or also involved with their family are at about half the risk of suicide. I think what really matters is that do they feel accepted? And so if the religious organization helps them feel accepted and loved, regardless of what their beliefs are, then their risk is reduced and it's successful in being a protective factor. Now we're talking a little bit about the LGBTQ youth and suicide risk. They're about 3 times more likely to consider suicide and 5 times more likely to attempt. The last I heard, and it may have changed, Utah's not collecting data for this, which would be interesting to know just specific to Utah what our risk is. But my guess, just from speaking to people, would be that it's as high as the national, if not even more so. Okay, so we did talk, I hinted at the benefits of a structured rating scale, and we'll talk about that in just a little bit. I think it's incredibly beneficial to get the family involved. So for those of you who are clinicians that are seeing patients in your office, trying to encourage them to have their families. And a lot of times they want to try to keep it a secret, but once they open it up and they talk about it, the risk actually goes down right off the bat most of the time because it's no longer a secret that they're hiding. Plus, your family is now your extended eyes and ears. They can be able to see things that you'll never be able to see. There are also some recommended interviewing techniques, and we won't really be able to go into that too much, other than just to say probably one of my favorite ways of bringing up the subject is without having somebody feel stigmatized is just to say, you know, it's very common for somebody with depression to have thought about suicide. Have you had thoughts of suicide? And then jumping in from there. And I've never had it go badly. So there is something called the Columbia Suicide Severity Rating Scale, and this is just one of many different scales that you can use. This happens to be the one that McKay Hospital uses. One of the things I like about it is you don't have to have any training whatsoever, and the structured format reminds us to ask about specific risk factors that we might have forgotten in the moment and protective factors as well. Also, it allows you to track over time to compare. So these are different ones that they have if you use the electronic medical records at McKay. They've got one that's a lifetime that you use. They got one for kids. They got one for follow-up. And this is the form. You can't see that from there, but I'm going to zoom in here. So questions 1 and 2, if you get past this, then you just continue. But if their answer is no, then you stop. So number 1, Wish to be dead. Have you wished you were dead and wished you could go to sleep, or wished you could go to sleep and not wake up? That's question number one. Question number two, have you actually had any thoughts of killing yourself? If they say yes, then you move on. Number three, have you been thinking about how you might kill yourself? Have you had these thoughts and some intention of acting on them? So you can see you're moving a little bit further with each question. Have you started to work out details of how you might do this? Have you ever done anything or started to do anything in preparation to end your life, and how long ago? Was it 1 year, 3 months to 1 year, or within the last 3 months? Okay, I know we're moving fast, but that's because we're about out of time. So risk management. This is what we were talking about before. If there's a risk factor for substance use, try to connect them to substance treatment. If it's alcohol, maybe naltrexone or another prescription. Get them in a support group. If there's some sort of stressor going on, try to get them into therapy. If there's bullying at school, involve the school counselor and parents. If they got depression and anxiety, try to address that. If there's a perceived lack of social support, try to see if that can be amenable. Access to means, secure the means. And if there's anything that I want you to remember of all of them, it's that one right there. And this is the one that I'm hoping you can pass the word to, help people to know. David Grossman, who's prior military and does a lot of studies on law enforcement, military in regards to violence and death and stuff like that, who's really interesting, said gun owners are not more likely than non-owners to consider attempt suicide. They're just simply more likely to die in a suicide attempt. That just means what we were saying was kind of obvious. So in Utah, over 80% of firearms used by the youth for suicide belong to a parent. More often than not, parents don't think the kids have as much access as they actually do. They've done 2 different studies. One of the ones is where the parents said, my kids have never touched the gun at home. Then they asked the kids, 22% of them said they either had or they knew how they could access it. They'd looked at it before. The parents did not know that. There was another study in an emergency room setting where they asked families where kids were coming in or people were coming in because of suicidality. 33, 1/3 of them had an unlocked gun at home that they could have accessed. It's not being talked about very often. It's talked about a little bit more, but not as often as we'd think. It can be a touchy subject. You know, you have a lot of people that can perceive the discussion of this as threatening. There's a lady named Catherine Barber who's an expert from Harvard who came here to Utah to help us as far as a community to be able to address this. And she brings up a nice way to be able to introduce the idea. So she says this: what some parents in my practice do when their child is really struggling is to store their guns away from home until things improve. I'm wondering if you'd consider a strategy like that. You may still have a few people that say, no, it's just not worth the risk. I gotta have something in case somebody breaks in the door or whatever. But more often than not, at least my experience has been that people are very open to the idea. So there's different levels of intervention. The worst is just to hide the gun. I guess that's better than nothing. Better, get a gun lock. You can go into any emergency room, at least in Intermountain, and they have gun locks available. Better than that is to store the guns unloaded and locked with the ammunition someplace else. And the best of all is you can store guns outside the home. Now, what if you have somebody and they don't live with anyone, they don't have any family members? Well, you could, if they don't have a friend or relative they can take it to, you can take it to the police. There's the safe harbor law. A lot of shooting ranges will rent lockers. You can have them put it in a storage unit. And I've found that if I tell people, I'd like to have our care manager give you a call and we're just going to follow up on how you've done, then they feel responsible and they'll do a good job at taking steps. I don't think I've remembered a time where they said, nah, I changed my mind. This is just for your information, crisis lines and other numbers. I know I really didn't give you much time for questions, and I apologize about that. But what were you going to say?
2 minutes.
2 minutes. Okay, I've got 2 minutes. So for those that have a question and can condense it down, go ahead. If anything, or a comment. I'd take comments too. Yes?
You began your presentation with an increase
So that's a great question, because now we're talking about not just completed suicides, but just people considering suicide. And that goes back to just hypotheses, but I mentioned, I think that social media may be one of those things that's putting people at greater risk. But I don't think it'd be fair to say that's the only reason. Yes?
What is it about social media that causes that?
There's probably some people here that have more experience and expertise in talking about this, but from what I understand, a lot of it, especially young females, is the comparison. So feeling like everybody's got this perfect life, because people don't usually tend to say, hey, I just, look at all these problems I have in my life and I'm posting it. They tend to post all the good things that are happening. And if you take it all, you see it, especially kids. It's hard to understand, even for me, and I'm younger than some people here. But the kids, they'll just scoop through these. They're looking at hundreds in an hour. And so what ends up happening, the unconscious mind takes this and sort of forms this conglomerate of all the best things going on with all these different people, and now they're comparing without necessarily realizing it. So that's just one, but I think that could be a whole lecture in and of itself.
So as a segue, what you mentioned, are there rates among women or girls higher than boys?
They don't have information right now that I'm aware of as far as like a subset of, teenage girls, if the rates are going up higher for suicide attempts or not. But that would be interesting to know. Sure.
That Columbia thing that you mentioned is very similar to what we do in the Air Force. Does it work?
Oh, absolutely. I mean, it's definitely helpful. I think that, like I said, I do forensic work, or I used to do forensic work. So in risk prediction or risk assessment, not just with suicide, it forces you to be able to be aware of every single question to go down. It makes it so that you don't have to know how to phrase things perfect. If you feel a little nervous, you just pull out the paper and just go off it. It also is something to compare to. So if you can see if the numbers are going up, then that is definitely concerning. So I don't see how you can go wrong by using them. Yes, Donald.
I consider Facebook one of the tragedies of history. End of statement.
Thank you. That's a good, strong exclamation to end on. All right.
Thank you so much.
Thank you very much. I appreciate your attention.